started, I'd like to thank our sponsor, Regeneron, who made this event possible. And the topic of today's event is treatment options for relapsed and refractory DLBCL. The agenda will be as follows. I will introduce Dr. Yilmaz, and she will speak for about 30 minutes. After the presentation, we'll open it up for questions and comments. I'd like to take a minute to introduce our speaker, Dr. Yilmaz. She is an assistant professor at the Department of Internal Medicine at UT Southwestern Medical Center. She specializes in indolent and aggressive lymphomas, cellular therapies, and bone marrow transplant. She earned her medical degree in Turkey. She completed residency in internal medicine at Sinai Hospital of Baltimore and gained advanced training in hematology and medical oncology through fellowships at George Washington University, Georgetown University School of Medicine. She's certified by the American Board of Internal Medicine, and she joined UT Southwestern faculty in 2022. Dr. Yilmaz is a member of the American Society of Hematology and the American Society of Clinical Oncology. She has delivered several presentations and published academic articles related to her area of expertise. We're so grateful that she's willing to join us today. And with that, I will turn the time over to her.
Thank you so much for the kind introduction. Let me just start sharing my screen. Okay, can you see them now? Can you see my screen?
Yes, I can.
Okay, perfect. Welcome, everyone. My name is Elif Yilmaz, and I am one of the lymphoma specialists at UT Southwestern Simmons Cancer Center. And today I will talk to you about the management of relapsed refractory diffuse large B-cell lymphoma. I would like to start with an outline of my presentation. First of all, I would like to give you some brief facts about diffuse large B-cell lymphoma, to tell you about what kind of lymphoma it is and what are the survival statistics. Then we will talk about how we define relapsed and refractory disease. Then we will go over the mechanism of action of potentially curative therapies in the relapsed refractory setting. And then we will review the treatment landscape for the second line and later lines of treatments in diffuse large B-cell lymphoma. This is a really nice figure dividing lymphomas in different subgroups. In general, we divide lymphomas into two main categories. These are Hodgkin lymphomas and non-Hodgkin lymphomas. Non-Hodgkin lymphomas make the majority of the lymphoma cases, and we further subdivide them into two groups: T-cell lymphomas, lymphomas arising from our T lymphocytes, and B-cell lymphomas arising from our B lymphocytes. Under the B-cell lymphoma group, there are three different classes, depending on how the lymphoma behaves clinically. There are highly aggressive lymphomas, and indolent lymphomas. The diffuse large B-cell lymphoma is the most common aggressive B-cell lymphoma. There are more aggressive lymphomas than this. For example, Burkitt. Aggressive and highly aggressive lymphomas tend to be quite curable, whereas indolent lymphomas are potentially curable in a small percentage of cases. What are the survival statistics with DLBCL? All in all, it's curable in about 6 to 5% of the patients, and the cure rate depends on the stage. This figure on the left is a really nice diagram showing how we stage diffuse large B-cell lymphomas and other lymphomas too. So you basically draw an imaginary line at the level of diaphragm. If the patient has only one area of lymph nodes involved, this could be just in the neck or in the chest or in the groin, then that's stage 1 lymphoma. If there are more than one group of lymphomas, but they're all at one side of the diaphragm, then it's going to be stage 2 lymphoma. If lymph nodes are involving the both sides of the diaphragm, then it's called stage 3. And if there is a solid organ on bone marrow involvement, then it is called stage 4. This graph on the right side gives you the 5-year relative survival rates for different stages. The 5-year relative survival rate gives you the likelihood of the likelihood of patients surviving the lymphoma. So, for example, in stage 1, about 80% of the patients with stage 1 DLBCL are not going to die from their lymphoma. They're going to be dying from other causes. And the range is anywhere from about 55% to 80% in DLBCL. So it is, all in all, highly curable lymphoma, even in stage 4 patients. About a third of patients who receive frontline therapy for DLBCL will eventually develop relapsed or refractory disease. What is frontline therapy? So you get a new diagnosis of DLBCL, and it's the initial treatment that they give you. Usually it's 6 cycles of R-CHOP or dose-adjusted EPOCH or something called POLA-R-CHP. Before we advance further, I would like to give you a bit more information about the terms we use in the treatment landscape. But first, let's start with the PET scan. This image on the right bottom shows you different imaging modalities that we use for staging of DLBCL and other types of lymphomas. PET scan is a fancy type of CT scan where they give patients a glucose dye that is attached to a radionucleotide, and that gets into the cancer cells, and then the areas with the tumor light up on the PET scan. So the image on the left side is how a PET scan looks. The image in the middle, how a CT scan looks, and the image on the right is PET CT. Basically, they fuse the PET images and the CT images together, and they make things to be seen much more easier. On the PET scan, anything brighter than the liver is concerning for involvement by lymphoma. But there are some exceptions to this, because PET scan measures the glucose uptake by the tissues, and yes, cancer takes up a lot of glucose into its cells, but also some of our tissues have a high baseline glucose uptake. Brain is one of them, and you see on the image it lights up the most. Or our heart uses a lot of, it has a significant amount of blood supply, and there is glucose in the blood, so it lights up. And then kidneys are the ones excreting the dye, so they will light up, and our bladder will light up because the urine has the dye. But again, all in all, apart from these areas, if you see areas brighter than the liver on the PET scan, then that's concerning for lymphoma. So let's go back to the terminology. What is complete remission? It's basically resolution of all abnormal activity that was present at diagnosis following the treatment. So that's the best response you can get to a treatment after for the lymphoma. What is primary refractory disease? It's failure to achieve complete remission with treatment or at the end of treatment. So you either have some of your tumor left at the end of your chemotherapy, or unfortunately, sometimes, although rarely, things might worsen while patients getting chemotherapy. So that's called primary refractory disease. Relapsed disease is a form of disease coming back basically after it goes away completely. So you get your chemotherapy, you achieve complete remission, everything on the PET scan goes away, but then sometime later, it could be months to years, your disease comes back. So that's relapsed disease. Early relapse is either primary refractory disease, so you either never respond to chemotherapy or you don't respond sufficiently, or your disease comes back in less than 12 months following completion of frontline therapy. Later relapse means disease comes back 12 months after or later following the completion of frontline therapy. One thing that we need to emphasize here is that early relapse indicates chemorefractoriness. If you're not achieving a good response to chemotherapy by the time you get an end of treatment scan, or your disease comes back very quickly after the initial treatment, then it means that your tumor is not really responding well to conventional chemotherapy. So we treat these patients differently. It's important to make that distinction. I would like to review the mechanism of action of some potentially curative therapies for relapsed refractory patients. The first one is probably the most popular nowadays is chimeric antigen receptor or CAR T cell therapy. Then there comes autologous stem cell transplant, which has been used for years and years. There is a different form of transplant that's called allogeneic stem cell transplant. And then there are new players in the treatment landscape. These are called BiTEs or bispecific T cell engagers. We don't know if they are curative yet. The clinical trials that are still ongoing, and to be able to call a treatment curative in DLBCL, you really need to follow these patients at least for about 5 years or even more to make sure that disease is not coming back, because the cure means the disease never comes back. So we don't have that duration of follow-up on the initial BiTE clinical trials, but definitely there are patients who have been having durable remissions beyond 2 years with BiTEs. So let's talk about CAR T cell therapy right now. We need to talk about, first of all, our T cells. T cells are a type of lymphocytes that are there in our body to help us recover from infections, clean up foreign substances in body, or clean up cancers that are forming in our body. But cancer eventually outsmarts the T lymphocytes sometimes and awaits the killing by the T lymphocytes. So in CAR T cell therapy, we make these T lymphocytes secrete a molecule or express a molecule on their surface called CAR molecule that basically recognizes the tumor cells, binds them, and then kills them. So the whole idea behind CAR T cell therapy is that it makes your own immune system go recognize and kill the cancer. It doesn't work in everyone. It works in roughly about 1/3 of the patients getting it in the relapsed refractory setting. But when it works, it can create miracles. There are multiple steps in how we administer the CAR T cell therapy. The first step is to do something called T cell collection or T cell apheresis. So basically, we put a central line on the patient's body, sometimes in the arm, sometimes in the neck. We connect them to a machine like dialysis machine, which filters their blood and collects these T cells. Then we send that collection of T cells to a manufacturer. The manufacturer transduces these cells in the laboratory and make them express these CAR molecules on the surface of T cells, and then it proliferates them. This process from company to company, manufacturer to manufacturer, takes anywhere from 3 to 6 weeks roughly. Once the product is ready, we give 3 days of light chemotherapy to the patient in the outpatient clinic. And then 2 to 5 days later, we will give this CAR T cell product to the patient and wait to see what happens. These CAR T lymphocytes are supposed to, again, go find tumor cells in the body and kill them. Again, only 1/3 of the patients will have durable responses to CAR T cell therapy, which is still a very big achievement in the relapsed refractory setting. There are 3 FDA-approved CAR T cell products that we use as standard of care. These are axi-cel, liso-cel, and tisa-cel. The manufacturing times of these products are slightly different, and the side effect profiles and efficacy profile are slightly different as well. There are lots of investigational products in the CAR T space. The FDA-approved products are all targeting the antigen called CD19 on the surface of tumor cells. The investigational products have different targets. This could be CD22, this could be CD79B. Some of the CAR T cells that are being investigated investigated are targeting two different antigens on the surface of cancer cells. It could be CD19 and 20 at the same time, could be CD19 and 22. There are ultra-fast CAR T cells that are made in one day. They're allogeneic CAR T products. They're basically off the shelf, ready to use right away. They're made from healthy donors, and the patients do not need to go through the T cell collection and manufacturing process. So this landscape, the CAR T space is just expanding very quickly. So the next potentially curative therapy is autologous stem cell transplantation. The whole idea behind autologous stem cell transplant is high-dose chemotherapy. Therefore, this is a good option only for patients who are chemosensitive. When a patient develops relapsed disease, we first of all start them on a treatment regimen usually contains of a few 2-3 chemotherapy agents that is called salvage chemotherapy. After 2 to 3 cycles of salvage chemotherapy, then we start the autologous stem cell transplant process if they are responding to the conventional chemotherapy. So basically, we give them a few days of injection, which is a growth factor that stimulates the production of stem cells, and those stem cells goes into the peripheral blood. Then again, we connect them to a machine like dialysis machine, filter their blood, and collect their stem cells. We send them to the stem cell lab where they're going to be processed and frozen. Then we admit the patient to the hospital to initiate high-dose chemotherapy, or that is called conditioning chemotherapy. After the conditioning chemotherapy is completed, we give those stem cells back to the patient. Again, these are patient's own stem cells. There are no donors in autologous stem cell process. And then following the infusion of the stem cells, patients stay in the hospital for about 2 weeks until those stem cells get settled in the bone marrow and start producing healthy cells. The total length of hospitalization for a typical autologous stem cell transplant is about 3 weeks. And again, this is only an option for patients who had chemosensitive disease. What about the allogeneic stem cell transplant? It is different than autologous stem cell transplant because we need a donor here. We are using somebody else's stem cells to treat the lymphoma. The idea behind here, not just the chemotherapy that we give with the allogeneic stem cell transplant process, but also something called graft versus lymphoma attack. So the initial steps are similar. With the difference that you need to identify a donor, which is an acceptable match to the patient. Then you collect the donor's stem cells, and then you admit the patient to the hospital and give them the conditioning chemotherapy. The main purpose of giving conditioning chemotherapy here is to destroy the patient's immune system so that somebody else's stem cells, the donor's stem cells, can go get settled in their bone marrow and start producing healthy cells. And again, the major advantage of allogeneic stem cell over autologous stem cell is something called graft versus lymphoma effect. So basically, these stem cells that are obtained from the donor that are settled in the patient's body attack the tumor cells as foreign, and they constantly destroy them. And in that way, they prevent the relapse of the lymphoma. When they're constantly attacking the tumor cells, sometimes they can consider patients' own healthy cells foreign and attack them as well. And this is called GVHD. There are different forms of GVHD. GVHD means graft versus host disease. So the donor cells are attacking the patient's, the host cells. It could be various grades and various stages. It could be a mild GVHD. It could be very severe, resulting in loss of morbidity. Again, allo stem cell transplant could be very effective in about half of the patients who have very relapsed refractory disease, but it is riskier than autologous stem cell transplant. So it's not for everyone. The type of patient who is supposed to get this procedure needs to be chosen very carefully because of the side effects. What about the bispecific T cell engagers, BiTEs? first of all, let's define the bispecific antibody. So bispecific antibody is an artificial protein that binds two different antigens or two different parts of the same antigen on the surface of a cell by means two. Bispecific T-cell engager, on the other hand, is a type of bispecific antibody where the molecule binds an antigen on the surface of cancer cells, and the other molecule and other binding site binds to a molecule on the surface of T lymphocytes. Therefore, it brings T lymphocytes closer to the tumor cells and causes T cell mediated killing of the tumor cells. These are considered cellular therapies. They're usually better tolerated compared to CAR T cell therapy. The side effect profile is better. They appear to be very efficacious as well, even in patients who are relapsing following CAR T cell therapy. One caveat with the BiTEs or bispecific T cell engagers is that they're multi-dosing drugs. CAR T cell therapy is a one-time treatment, whereas BiTEs have to be given regularly, sometimes until disease progression. And there are certain products that have time-limited treatment regimens too, but it's again at least 8 times or 16 times depending on how the patient responds. So these are the BiTEs. So there are some already FDA-approved products in the BiTE space. These are mosunetuzumab that is approved for follicular lymphoma, and glofitamab and epcoritamab are approved for diffuse large B-cell lymphoma. These are all targeting CD20 molecule on the surface of cancer cells and CD3 molecule on the surface of T cells. There are lots of investigational products, again, in this space too, targeting different antigens. There are now trispecific antibodies that are targeting two different molecules on the surface of tumor cells, whereas the third molecule binds to the T cells. So it's very exciting what's going to happen within the next few years. So let's talk about the treatment landscape in patients that are having their first relapse or who are primary refractory. The first thing that you look at is whether the patient is autologous stem cell transplant eligible. Autologous stem cell transplant could be done in majority of the patients. Age sometimes could be a limited factor, but not always. Sometimes age is just a number. If the patient is a 70-something-year-old but have a really good stamina, really doesn't have much other medical problems, they could be transplant eligible. So once you make that determination, and if they are transplant eligible, then you look at the timing of the relapse. If this is a primary refractory disease, never responded to chemo, or relapse within the 12 months of completion of chemotherapy, then the standard of care treatment here is CAR T-cell therapy with axi-cel and liso-cel. These products are very similar in their efficacy. In this space, in patients who have early relapse, both axi-cel and liso-cel cures about a third of the patients. It may not sound great, but these are the patients who are chemo refractory. So curing a third of them just with one treatment is actually a pretty amazing, pretty good success. What is the main difference between the axi-cel and liso-cel? It's the time that is required for the manufacturing. Axi-cel can be manufactured in about 3 weeks. Liso-cel takes a bit longer. It's at least about 5 to 6 weeks. Liso-cel has a better side effect profile than axi-cel. So if I have a patient who is not very fit, but still a candidate for CAR T-cell therapy, I tend to prefer liso-cel. Otherwise, axi-cel helps us move quite fast. What are the other options other than CAR T-cell therapy for early relapse patients? Obviously, the clinical trials. And clinical trials really should be the first thing that we should think about, because that's really how we advance the science and how we make the treatments better for future patients having this disease. Going back to the transplant eligible patients, if they're having a late relapse, so if their disease is coming back at least more than 12 months after completion of initial treatment, then the standard of care option for these patients is autologous stem cell transplant. Usually, before we give autologous stem cell transplant, we give these patients 2 to 3 cycles of conventional chemotherapy that is called salvage treatment. That usually contains a group of medications called platinums that are very effective. And autologous transplant in this space can cure around 50% of the patients. So going back to the transplant determination, if a patient with relapsed refractory DLBCL transplant ineligible and they're having their first relapse, then we look into see if they're a CAR-T candidate. There are going to be very few patients who are not CAR-T candidates. If they're CAR eligible CAR-T candidate, then liso-cel is approved in this space. Again, even in patients who are a bit more frail, transplant eligible, since liso-cel has a better side effect profile, and actually it got prospectively studied in this setting in a clinical trial, liso-cel is now approved in this group of patients. If they are transplant ineligible and CAR-T ineligible, that means that they're very frail. So they're not going to be candidates for clinical trials most of the time. So options for treatment at that point will be novel agents, targeted therapy combinations, bispecific antibodies, and best supportive care. And let's talk about patients who relapse more than once. They are having their second relapse or third or fourth. What do we do for these patients? The first thing we look at whether they had CAR T cell therapy or not prior to this relapse. Oftentimes, nowadays, by the time patients get second or third relapse, they will be already through an anti-CD19 CAR T cell therapy. So if they got prior CAR T cell therapy, then the first thing we really should think about is an enrollment to clinical trials. There are lots of clinical trials at our academic centers, at many other centers, testing different CAR T cell therapy products. So those could be an option. Bispecific antibodies are approved and standard of care in this setting. And there are also multiple clinical trials going on with bispecific antibodies and with their combinations with chemo or targeted therapies. If the first two options are not happening, we can try novel agents. In patients who are refractory to CAR T cell therapy, allo stem cell transplant could be a treatment option if the patient is fit enough. And but again, as in the case of auto transplant, allo transplant also oftentimes needs to be preceded by a combination treatment to decrease the amount of disease the patients have. Studies shown in that space that patients who benefit from allo transplant in the long term, and if they're CAR T refractory, these patients are the ones who have complete remission to the treatment that was given just prior to the allo transplant. So let's say you had your third relapse and your doctor started a treatment and you only had a partial remission, or you did not respond to that treatment, you're having progressive disease, then unfortunately you are not a candidate for allo transplant because you are not going to benefit from that most likely, and the side effects or the risks of the treatment really triumphs the benefit of the treatment. But if your doctor started you on treatment and you're responding beautifully, you had a complete remission, then yeah, even though you are CAR T refractory, you could really benefit from the allogeneic stem cell transplant. And if none of these things are happening, then obviously we need to think about the best supportive care. So if a patient who is having their second relapse or further, and if they did not receive prior CAR T cell therapy, and if they're CAR T eligible, then obviously we can give them the FDA approved CAR T cell therapies like axi-cel, liso-cel, tisa-cel, or they could get a clinical trial. They could get a CAR-T through a clinical trial here. If they are CAR-T ineligible, then we can think about bispecific antibodies because overall they're better tolerated than CAR-T. So a patient who is not eligible for CAR-T could be eligible for bispecific antibodies potentially. And then if that's not happening, we can think about novel agents and that supportive care. So what are these novel agents that I'm talking about? These are mostly targeted therapies. There's a medication called polatuzumab, which is very active in certain types of DLBCL. It is an antibody drug conjugate. So an antibody molecule is attached to a conventional chemo agent. It binds to the tumor and delivers that conventional chemo agent in a targeted fashion. So polatuzumab with bendamustine rituximab chemotherapy was studied in this setting, could be one option. Oftentimes we omit the bendamustine if we are giving polatuzumab, if we are going to give the patient CAR T cell therapy after. There's a combination regimen called tafasitamab and lenalidomide. There is loncastuximab, which is another antibody drug conjugate targeting CD19 molecule. These options are more effective early on in the treatment of relapsed refractory disease, if especially the tafalin and lonca, if they're given in a patient who have CAR T failure, unfortunately they do not work very well. That's pretty much the end of my presentation. So as a summary, relapsed refractory DLBCL is still curable in about 30 to 40% of the patients. Immunotherapy with CAR T cell therapy is the preferred treatment modality in patients who have chemo-refractory disease. Again, never responded to first-line therapy or not responding to a conventional chemotherapy regimen that they're currently receiving. Autologous stem cell transplant is a curative option in patients with late relapses and chemosensitive disease, and oftentimes it is tolerated well. If you give it to the right patient, it's definitely less toxic than allogeneic stem cell transplant. Enrollment in clinical trials are very important and should be a priority at every step because that's how we advance the science and, again, how we make it better for future patients. And if you're a lymphoma patient treated by a community oncology provider, and if you're going through a relapse that has been recently diagnosed, then please get a second opinion by a lymphoma specialist, someone who only sees lymphomas, to make sure that you're being given the right treatment. So that's all my presentation, and now we can answer the questions.
Thank you so much for that. That was amazing, and you did a wonderful job. Let me just switch to my screen real quick. Okay. Can you see that okay?
Yes, we can see your screen.
Okay, so now we will have the discussion part of the event. And as a reminder, you can ask a question by typing in the chat box, or you can raise your hand and ask it verbally. While I wait for questions to be typed in, I had a couple of my own. When you talked about remission that occurred greater than 12 months or sooner than 12 months, is one or the other a better outlook? Are they equal? When you see that, what do you think of?
Yeah. Later relapses tend to be, all in all, a bit more curable than early relapses. Again, early relapse indicate chemorefractoriness, which can sometimes make things challenging. I mean, obviously, things are much better right now than 10 years ago. 10 years ago, patients going through an early relapse did not really have a lot of curative treatment options. Now we have all these immunotherapy modalities, CAR T cell therapy, bispecific antibodies, trispecific antibodies. So the outlook of those patients with early relapse is much better right now, but still a bit worse than patients who are going through a late relapse.
Okay, perfect. Thank you. So Mary asked, I'm worried about relapse. What kinds of signs and symptoms should I be looking out for when that would tell me I'm starting to relapse?
A significant percentage of the patients with DLBCL, if they are starting to relapse, they will have similar presentation to what they had before at diagnosis. So if you're having symptoms reminding you what you went through just prior to your diagnosis, that's a bit of a red flag. Um, Again, DLBCL is an aggressive lymphoma. Oftentimes, things escalate rather quickly compared to other slow-growing lymphomas. So there's something called B symptoms. These are unexplained fevers. They're usually low-grade, drenching night sweats, or unexplained weight loss. You're not trying to lose weight and you're eating as usual, but you're still rapidly losing weight. So these are the some symptoms. And actually, pain could be a presenting symptom, and these symptoms are famous in the lymphoma world. But if you look at the percentages, pain is a more common presenting symptom than B symptoms. So that if you have a pain that is unexplained, that is constantly getting worse, then it's concerning for lymphoma. I mean, we have pain all the time for various reasons, like we can get headaches that come and go, or back pain come and go. If the pain is mild, it comes and goes, unlikely to be the lymphoma. Usually lymphoma related pain, and if it is DLBCL especially, tends to escalate over time and becomes persistent. So these are the things. Very rarely, about 5 to 10% of the patients with DLBCL will have something called central nervous system involvement, involvement of the brain and the spine and the nerves. So if that is there, there could be headaches, vision changes, there could be numbness or hand or feet weakness. So, but those kind of symptoms are rare because CNS involvement is fortunately not very common in DLBCL.
Okay. Thank you. So when you say pain, is that just in general pain or like specific areas?
It's usually a localized pain that you can like specifically define.
Okay. Okay.
Yeah.
Let's see. Elise asked, is there anything patients can do to avoid relapse with these therapies? What makes some patients relapse while others don't?
Um, it's basically the disease characteristics and the molecular structure of the disease rather than what you eat or what you do. It's really not related to, I mean, I get this question all the time. Unfortunately, there is no magic diet or supplement that will prevent a relapse. Oftentimes, what I recommend my patients who complete frontline therapy is that just live a healthy life, exercise regularly, eat a balanced diet, so that if your treatment comes back, if your lymphoma comes back in the future, and if you need another line of treatment, it really helps a lot to have really not much other medical problems. But other than that, there is really no magic diet or unfortunately a supplement that will prevent a relapse.
Perfect. That makes sense. Okay. And Megan asked, CD19 can cause B cell aplasia, killing off the cancerous and healthy B cells. Do CAR T cell products that target other binding sites like CD22 also cause B cell aplasia?
Yes, technically they can because these antigens, CD19 and CD22, are common B cell antigens. What I mean by that, they are present on the surface of all B lymphocytes, healthy or cancerous. So technically, all these products targeting B cells can cause B cell aplasia, which is the depletion of the B lymphocytes.
So these antigens are normal and healthy. It's just when they become a problem that they're treated, or are they not normal?
These antigens just are molecules. How should I define it? For example, I mean, it's really a unique features of that group of cells. For example, T cells have different set of antigens on their surface. B cells have different set of antigens on their surface. That's how our body recognizes, aha, this is the B cell, and aha, this is the T cell. So these are the recognition markers per se. They are going to be present on the surface of both healthy and cancerous cells.
Yeah.
So when we design targeted therapies, we try to design therapies targeting these antigens.
Okay, that makes sense.
Yeah.
Mariana asked, are these treatment approaches equally effective across all age groups? I think DLBCL is more common in older patients, but I personally have a friend in her 20s with DLBCL, and I'm wondering whether the options for her are the same.
Mhm. Considering that a patient is having otherwise overall good health, the efficacy of these treatments, especially the immunotherapy, is pretty similar across all age groups. But sometimes with transplant, it could be a bit different because transplant tends to have more acute toxicities compared to CAR T. So if the age sometimes obviously can make the patients frail, and they might have an adverse events while going through the transplant process, and it could decrease the or worsen the outcomes for that particular patient. But again, especially for immunotherapy, outcomes are pretty similar across the age groups.
Okay, thank you. Let's see. Andrea said, what common strategies would you recommend newly diagnosed patients to follow? Should they exercise more, eat certain foods, etc.?
Um, Usually, a patient with VLBCL, the types of treatment we give to patients who have newly diagnosed DLBCL are not very toxic chemotherapies. These are usually R-CHOP or Pola-R-CHP. A small percentage of patients are going to get a bit higher dose chemotherapy regimens like dose-adjusted EPOCH-R, but even that is quite tolerable for majority of the patients. So I oftentimes tell my patients, if they're especially working from home, please continue to work at least partial, like part-time, because that really eases the mind off and help the patients concentrate on something other than their disease. So mentally, I see that continuing to work helps a lot. I definitely ask them to continue exercising. Obviously, you need to listen to your body, and if you need to take rest, you need to take rest. And usually these are the treatments that are given once every 3 weeks, and the energy level of the patient is going to be a bit down during the second week, so I ask them to rest during that period. But the first and third week, they should definitely exercise as much as they can do. And regarding the diet, I mean, it's a very pretty much the same answer for me. Just eat something healthy. I mean, well balanced. Oftentimes, these patients do not struggle with weight loss when they're going through chemotherapy. Actually, majority of my patients tend to gain some weight once they start chemotherapy because they would be losing some weight prior to the diagnosis, and as soon as they start treatment they start feeling better, and that increases their appetite. And then we also give them steroids, usually 5 days every cycle, and that stimulates their appetite too. So I mean, there are really not much restrictions as to what they can eat, but obviously it helps to eat healthy overall.
Yeah, those are great strategies. Mary said, I've heard getting access to CAR T cell therapy can be challenging. Is this true?
Yes and no. I mean, I live in Dallas and I practice in Dallas. It's a city in a very big state, and we do get referrals from far away for CAR T cell therapy. It really depends on the institution. For the distance to medical center standpoint, if we have patients, for example, coming from far away to UT Southwestern for CAR T cell therapy, we provide them housing for a month following the CAR T cell therapy. So that makes it accessible to those patients. And a lot of academic centers provide this housing option for their patients if they're far away from the academic centers they're treated at. So that's one access of that's one part of the treatment access, that is distance to medical center. The other part of the access to CAR T cell therapy is the insurance. Unfortunately, Medicaid does not pay for CAR T cell therapy, and Medicare requires supplemental insurance to cover the product costs, because these therapies unfortunately are still very, very expensive. Most of the commercial insurances will approve CAR T cell therapy, but again, if you have Medicare and no supplemental insurance, or if you have only Medicaid, then it's going to be challenging. Academic centers like UT Southwestern will have financial assistance programs for patients who do not have the financial ability to pay for these treatment modalities. They will have their own restrictions, but it could definitely be a supplementary tool to make these therapies accessible to the patients.
Great. Thank you for sharing that.
Mhm.
So, Katie wanted to know, can you talk about the most promising DLBCL trials that you're involved with at UT Southwestern?
So basically, we're trying to focus on patients who are having CAR T failure because anti-CD19 CAR T cell therapy is standard of care for relapsed refractory patients right now. It could be given in a lot of places outside of the academic centers too. But since we're an academic center, we have the luxury of giving a budget to do research and the most need in the relapsed refractory treatment landscape is to advance treatment for patients who are refractory to CAR T cell therapy. So we do have multiple CAR T products that are targeting different antigens, CD22, CD20. We do have bispecific agents as monotherapy or combined with other treatment modalities in this space. So it's mainly cellular therapy based clinical trials. There are also a set of phase 1 trials that are introducing brand new molecules in this space as well. So that's what we are trying to achieve as a lymphoma program at UT Southwestern.
Thank you. Megan wants to know, what are common side effects of bispecific antibodies and what are general side effect solutions?
That's a great question. These cellular therapies, both CAR T and bispecifics, have two main toxicities. The first one is something called CRS, cytokine release syndrome. The other one is called ICANS, or neurotoxicity, that is associated with T cell therapies. So, what is CRS? It's an hyperinflammatory state that is caused by those T cells. After you receive the CAR T cell or bispecific T cells, while those T cells are going and killing the cancer cells, sometimes it can create a lot of inflammation in the body, and that can cause fevers, issues with breathing, issues with blood pressure. There are different grades of these toxicities or side effects. Depending on the grade, our action plan is going to be different. And neurotoxicity is caused by the inflammation in the brain or the spine that are caused by these T cells. We oftentimes treat that with steroids. I mean, that's the first thing to do. The risk of these toxicities with bispecifics are much less compared to CAR T cell therapy, and that's the beauty of it. Although it's like you need multiple infusions of bispecifics, it's overall better tolerated than CAR T cell therapy. Oftentimes the toxicities could be there, but usually they're just grade 1, meaning that they're just very mild, that could be managed at the outpatient setting without the need for hospitalization.
Okay, perfect. I have kind of a question because you mentioned how important clinical trials are for you.
Mhm.
Uh, when I've had experience in clinical trials, I get a lot of hesitancy from patients and they're very cautious of joining clinical trials. What would you say to someone who has a lot of concerns, but maybe that's their only option left? What would you say to help them feel better about that?
I mean, if they're meeting the criteria, the checklist, and if they had a really good conversation about their physician about what side effects are expected, they should just go ahead and get enrolled if this is their only option. And even if there are multiple other options, I would still try to prioritize the clinical trials, because clinical trials are the reasons, or clinical trial participants are the reasons why we have so good outcomes nowadays in the treatment of diffuse large B cell lymphomas, and that's how we can make it even better in the future. I mean, we really need those patients, and we value them a lot. There has to be obviously a sheer clarity between the patient and the physician about what are the trial procedures are, what are the potential side effects, and what are the action plans if patients encounter those side effects. once those are discussed very well, and especially if the patient do not have any other treatment option, then I do recommend them. But I also respect the patients if they went through multiple options and yes, there is a clinical trial available for them, but at that point they just don't want to keep going because they could be tired, and there could be at a stage in their life that they do not want to maintain that treatment schedule or the effort anymore. I do respect those patients, but if they're willing to be treated and clinical trials are the option, they should definitely consider them.
Okay. And I have one last question as well. So when patients go into remission, how often do they need to come in for monitoring or checkups? What tests need to be done and how often is that?
That's a good question. So once they complete the frontline therapy, and if they're in complete remission, then I do see them once every 3 months the first year. I usually do scans, surveillance CT scans at 6 months and at 12 months. If there is no evidence of disease coming back, then I do not do further set of CT scans. This varies a lot from practice to practice. Some practices will do surveillance scans once every 3 months during the first year and once every 6 months during the second year. There are some lymphoma specialists who do not do any surveillance scans at all. National Cancer NCCN guidelines recommend at most 2 sets of CT scans, surveillance CT scans that are given 6 months apart during the first year. So I tend to follow them unless I have a specific reason. But obviously, you need to consult the patient very well at the end of treatment visit about the potential symptoms of a relapse. And if that happens, you ask the patient to reach out to you sooner, not wait for their 6 month or 3 month appointment, and then repeat a scan at that point if the findings are concerning enough.
Perfect. Thank you so much for answering all those questions. I have a few closing remarks and then we'll go. Let's see. I wanted to mention our program Cure Hub. It's very important to us, and at HealthTree, we believe that educated patients and researchers create better and faster cures. We empower patients with that when they have the knowledge and then they actively participate in their health journey, that research can also provide researchers with valuable insights and real-world experiences like yours. We invite you to join the 12,000 and counting blood cancer patients who are currently impacting their outcomes while accelerating research by participating. Here's some things that Cure Hub provides the ability to do. It connects you to surveys and studies submitted by DLBCL experts, securely connects your medical records to track your disease within one single user-friendly interface. You can discover clinical trials personalized to you. You can anonymously connect to your genetic twin matches. And lastly, you can gain access to a database of side effect solutions provided by other blood cancer patients. On the bottom of this slide is the link for this Cure Hub. And as a quick reminder, our next adult DLBCL chapter event will take place on February 28th. It will be a pre-recorded podcast, so the audience will need to submit questions in advance, and that would be by February 23rd. You can submit questions by registering for the event on our event website. There will also be a live virtual roundtable in April with 3 DLBCL specialists. And once that roundtable is also published on the website, you can register for that as well. And thank you again to Regeneron for sponsoring this program. Thank you so much for everyone who came, everyone who asked questions and participated. And thank you so much, Dr. Yilmaz, for taking the time out of your day to be here with us.
Of course, my pleasure. I would like to make one final remark that is very important for our patients' well-being. Oftentimes, what I see in the clinic that patients' anxiety ramps up significantly when they complete the treatment. That is the anxiety of, oh, what if my disease comes back? Because they know that about a third of the patients with this disease will eventually relapse. And while they're getting treatment, yes, they may have some anxiety, but they feel like they're doing something for their disease. They're fighting, they're in the fight mode, they're getting chemotherapy. Once they're done with their end of treatment PET scan, then, they feel like they're not doing much, and what if the treatment comes bad? So at that stage, if a patient is experiencing that, and again, a lot of the patients do go through this phase, getting psychotherapy could be very helpful. For example, at UT Southwestern, we do have a division called psycho-oncology. I oftentimes refer my patients to psycho-oncology if they're okay and if they complete a treatment. And it's all behavioral therapy that really helps patients ease that anxiety and help them, keep going on with their life without thinking too much about their lymphoma. That really impacts their overall health being, because your life is forever changed. Even though you're cured, there are some long lasting impacts of the lymphoma and the lymphoma treatment on your body and mind. So it's very important to ask for help and get help if you feel like this is too much to handle mentally.
Thank you for adding that comment. That's very helpful. We
Sure.
appreciate you.
hmm Of
Have a
course.
great day, everybody.
Bye, everyone.
Bye-bye.